Today I have the pleasure of introducing Reade A. He's Assistant Professor of Neurosurgery and Radiology. He's Director of Neurointerventional Spine. He's Director of Cerebrovascular Services at Mount Sinai, Queens. He did his... Today I have the pleasure of introducing Reade A. Sorry, one second. He's Assistant Professor of Neurosurgery and Radiology. Live stream activating. He did his undergraduate and medical degree at University of Queensland in Australia. He did his residency at Gold Coast University Hospital and did multiple fellowships until coming to us at Mount Sinai for his neuroradiology fellowship and endovascular fellowship. He is an exceptional mentor. He is technically gifted, and he's also very compassionate with his patients. He recently was a recipient of the Coleman Family Award for Excellence in Physician Communication at Mount Sinai Health System, which really is a great honor. Thank you very much, Reade A. Look forward to hearing you speak.
Thank you, Chris. Very kind introduction. I'm going to share my screen and just confirm that you can see the slides. Go to presenting view, is that right?
Yeah.
Great. Okay, I'm going to minimize that. So, as Chris introduced, my name is Reade A. I'm one of the assistant professors in the cerebrovascular group here in Mount Sinai. I'm going to talk today about central retinal artery occlusion, and I wanted to be a little bit optimistic and say defining the role of neurointervention rather than is there a role for neurointervention, because I think the former is more accurate. Let me go forwards. So no disclosure is really relevant to this talk for today, but central retinal artery occlusion is rare. Paper that was published back in 2005 gave an incidence of 1 presentation per 10,000 ophthalmology visits. And most of us remember from our training back in medical school, but basically sudden onset painless loss of vision secondary to occlusion of the central retinal artery. And there's something to remember that it's impaired perfusion to the inner retinal layers. There's actually a dual supply of blood to the globe from the choroidal and ciliary arteries, which actually supply the outer layers of the globe itself. But it presents with decreased visual acuity, and on fundoscopy, the typical findings that we hear ophthalmologists and neurologists talk about of a pale retina and a cherry red spot. And it's important to understand that for the diagnosis of this entity, you really need a good quality physical exam that focuses on retinal examination, which is more or less a bit of a rate limiting step to getting patients treated quickly. And we'll talk more about that a little bit later on. But other investigations, CT had to exclude intracranial causes for presenting with visual loss, so excluding stroke, mass lesion. And as we talked about, fundoscopy, OCT, or fluorescein retinal angiography. And obviously the last two of those require technical considerations, but also expertise considerations. And then blood tests such as CBC, coags, ESR, looking for vascularity, underlying causes, and biochemical analysis. The image on the right is actually an OCT image. And again, we'll touch on this more towards the end of the talk, but basically this is a snapshot that gives you a bit of a topographical appearance of the retina. Talking to some ophthalmology colleagues, this is a more typical finding that you'd see in central retinal artery occlusion. So the arrow traveling across the center of the green box is the slice in which we're looking at the retina, which is depicted on the right. The mound on the left, and then there's a valley and then a mound on the right, is essentially the edema or swelling of the inner retinal layer either side of the fovea around the level of the macula. And that apparently is typical for what the ophthalmologist will see in central retinal artery occlusion. So why is it important? The natural history suggests that spontaneous visual improvement can occur in some forms of CRAO, but we'll talk a little bit about the numbers of that happening a little bit later on. But the extent of improvement really depends on the type and the duration of the CRAO. And when ophthalmologists talk to us about response, they're really talking about meaningful improvement. So 3 lines on a Snellen chart or a logMAR chart. And this only really occurs in 10% of patients with spontaneous reperfusion. So 80% of all comers that present with CRAO tend to have or will have a final visual acuity of counting fingers or worse. So why, what are the impediments that we have to fixing these patients? One is delay in presentation. So they tend not to present as quickly to emergency departments as those with major strokes or moderate strokes. And they tend to present to their community ophthalmologists or their primary care physicians rather than the ED first. And of course, there's a tremendous lack of standardization in the treatment that's been offered, either conservative or interventional therapy. So etiologically, 95% of these patients are thromboembolic. the cause of CRAO is thromboembolic, so either cardiac or vessel-to-vessel from the ipsilateral carotid artery, with 5% being arteritic, so that zebra that people talk about with giant cell arteritis presenting with monocular visual loss. We talked a little bit about the type of the CRAO influencing patient outcome, and that's the second line there. So is it a complete CRAO where the entirety of the retina is losing its blood supply? Or is there a normal variation in which a patient has a cilioretinal artery? And in those patients, we'll show a diagram, but essentially the central visual field, the macula and the fovea, can be supplied by a separate artery that arises not from the central retinal artery, but by a ciliary artery. So this talks a little bit about the natural history. It's a little bit of a busy slide, but I'll try and dissect it apart for you. So the top section is visual acuity at initial presentation by type of CRAO. And essentially what we're looking at is the non-arteritic CRAO variants. So no giant cell arteritis patients. And this is complete and with cilioretinal sparing. And you look at the presenting symptoms. So 93% of patients with non-arteritic CRAO will have counting fingers or worse. So really, really debilitated vision in that eye. Slightly better for patients with that cilioretinal artery sparing, which makes sense because they have the center of the visual field somewhat preserved. And when you take this section over to the right and you break it down to see what happens with the natural history of these patients over time with spontaneous recanalization or reperfusion, essentially the non-arteritics, only 1 in 5 of those patients will get some marginal improvement in their vision. So the natural history is very, very poor. So the cilioretinal artery here is a branch that can come, pierce through the choroid, pierce through the retinal layers, and supply the retina, usually within the temporal quadrants, away from the optic disc towards the macula and the fovea. And obviously that's the center of the visual field. Only about at least reported 5 to 50% of patients will have this normal variation. So it's not a reliable finding. This is fluorescein angiography. So complete CRAO on the left. We don't see any fluorescein traveling through the arterial arcades, and this is at 90 seconds. And again, ophthalmology colleagues tell me that you should see the arcade somewhere between 15 and 20 seconds. And this is a patient with cilioretinal sparing. So fovea, macular region, optic disc, and there is some preservation with loss of the opacification of the arteries adjacent. So delay in presentation is a major, major problem. This gentleman here, Hare, has published the majority of data looking at how long a retina may survive without adequate perfusion. So he identified that irreversible damage to the retina occurs at 240 minutes after CRAO, specifically in rhesus monkeys, so not in humans, obviously. But no permanent injury occurred in this group of subjects if retinal flow was restored within just over 90 minutes. No recovery was found over 240 minutes. So based on the results from these animal studies, at least, and some human studies that we'll talk a bit about in coming slides, it suggests that the time and tissue measure that we use for evaluating and assessing stroke equally applies to the retina with terms to reperfusion. There's obviously significant impediments to us getting to these patients within this 4-hour kind of time frame, again, because problems with diagnosis in the hospital, but even upstream of that, problems with patients presenting promptly. So these are the therapies that have been used or have been investigated. Anytime that you see a list of this many interventions for a specific condition, it makes you wonder about the effectiveness of any or all of them. But non-invasive and intraocular therapies include IOP lowering medicines, reinhalation, ocular massage, hyperbaric oxygen, sublingual GTN or isosorbide, anterior chamber paracentesis, laser embolectomy, vitrectomy, and direct central retinal artery massage, IV TPA, and of course interventional therapies, which we're going to talk a little bit more about. So intraarterial lytics, of which the first cases were described back in the mid-80s. These days, TPA is obviously the most commonly used drug for IA therapy. We were using anterior chamber paracentesis at Mount Sinai, but that's fallen out of favor. There have been some studies showing that there's no difference between patients that have that intervention and not. There is a study that was done out of the Mayo Center looking at hyperbaric oxygen, which had some encouraging results, but obviously most hospitals or many hospitals don't have those kind of facilities available readily. And there was an IV TPA trial that came out of Australia, which was an RCT, but again, very small numbers, only 18 patients randomized. and not really powered. It was more of a pilot study. In terms of level 1 evidence, the Eagle study is the only level 1 prospective randomized trial looking at intraarterial therapy for central retinal artery occlusion. This was published back in 2010. So they get top marks for naming the study because it's an awesome name to give to a study. But the European Assessment Group for Lysis in the Eye, they enrolled between 2002 and 2007 for 84 patients. So it's very slow to enroll, which gives you insight about the rate at which these patients present, but also just the general incidence. And as I said, 9 centers between Austria and Germany. 40 patients were randomized to conservative therapy and 44 to local infusion therapy. They included patients between 18 and 75 years old. And interestingly, they allowed inclusion if the procedure would be able to start out to 20 hours, which kind of flies in the face of the research done by HiRA some years earlier. And primary efficacy outcomes were best corrected visual acuity at 1 month, and of course, primary safety outcomes for intervention. The medical therapy arm, they used hemodilution if the hematocrit was over 40, ocular massage for 15 to 30 minutes, timolol, acetazolamide, anterior chamber paracentesis was not allowed, and patients got BD low-dose heparin. If they're in the intervention arm, they got all of these interventions plus direct catheterization of the ophthalmic artery, bolus patient with 5,000 units of heparin, and 50 milligrams of TPA administered directly to the ophthalmic artery with intermittent examinations. And unfortunately, they showed no difference in best corrected visual acuity between the 2 groups at 1 month. And if we look at some of the demographic data on the right, the average time to intervention in the conservative therapy arm was almost 11 hours, and in the interventional arm was out to 13 hours. So really well and truly beyond what we postulate to being the sweet spot for intervention in these groups. So what we think is that time played a role, but there was significantly less recovery improvement in the logMAR. So that's a scale for assessing visual acuity, similar to Snellen, but more used in research applications. So significantly less recovery improvement in the logMAR chart for each hour lost per treatment. So speed is key, we're thinking. And again, like we said, really delayed presentations and delayed time of intervention. And again, the adverse reactions, we talk about the safety outcomes. So in the conservative therapy, 1 patient ended up with corneal erosion. And in the lytic therapy group and the IV heparin therapy group, 2 patients developed intracranial hemorrhages. And there were a number of more mild AEs throughout both groups, mostly in the intervention arm. Those things were things like groin hematomas, etc. So we rewind a little bit to a study that came out of the Hopkins group in 2008. And I say this, or I go to this, because it's this study that's really informed the way that we practice within the CV group in terms of our interventional strategy for these patients. So this paper was in stroke. It was a single center, non-randomized interventional study of consecutive patients. 21 patients got local therapy, 21 patients standard of care, 76% of visual improvement of 1 line versus 33%. And there were no intracranial bleeds or visceral bleeds or retroperitoneal bleeds. So this is what we do at Mount Sinai. So we infuse TPA directly into the ophthalmic artery. We only infuse until the blockage is relieved or the patient's vision improves on the table. And we do it in 3 milligram aliquots at 5-minute intervals only up to 22 milligrams. So from their study under multivariate logistical regression, patients who received TPA were 36 times more likely to have improvement. When we look at their time to presentation, essentially those that got intervention were on average taken to the interventional suite at 3.5 or just short of 3.5 hours, which is from onset, which is truly remarkable when you think about it and the barriers that people have to treating these patients. So, weaknesses, retrospective, non-randomized, and theoretically, they might have caught a number of CRAOs that have spontaneously recovered, or maybe they had a number of CRAOs that had cilioretinal artery sparing, but fluorescein angiography is not practical really in evaluating these patients in most settings. So we fast forward to 2021, and this is our group. So it's made up of members of the CV team, and importantly, it's made up with members and leaders within the ophthalmology team. And this was published in Clinical Ophthalmology earlier this year. So we published a retrospective consecutive series of 15 patients. These patients had to be treated within 12 hours. It was over the last 5 years from when our records could be sourced from the EMR. And the MSH protocol for IATPA was based on a Hopkins technique. After treatment with ITPA, we saw a significant improvement of visual acuity with mean change of 0.76 on the logMAR scale, and that was significant, and vision improved by greater than 3 lines in over 50% of the patients. And of these patients where vision improved, the average was by greater than 6 lines on the logMAR chart, on the Snellen chart, which is really quite impressive. And 4 patients improved from counting fingers at baseline or worse to 20/80 or better. Mean dose of TPA was 17 milligrams, and we got to them relatively quickly, but the fastest was 5.5 hours, so still barriers to care, and importantly, no adverse events. This is the box plot basically showing, and we'll look more so at the cutout on the right, but for the patients that had 3 lines or better at their follow-up at 3 weeks, this really demonstrates the magnitude of improvement from presentation, and of course, this was statistically significant. Similarly, same data in the previous graph, just shown in a different way, showing the spread of the change in visual acuity on the Snellen chart for those patients that had greater than 3 lines of improvement. So Mount Sinai Health System, we have data, I think at least, available to suggest IA therapy can lead to better outcomes for CRAO patients than the natural history and conservative care strategies when treated very early. Natural history is poor, and the risk of intervention using the technique that we apply, and at least the published data from Hopkins, appears to be very, very good. So we've had 36 patients between them with no serious adverse events or bleeding complications. Mount Sinai is obviously a very large network. We have lots of sites. We have an extremely well-organized LVO evaluation and treatment network and well-integrated stroke neurology, ED, CV, NSICU, and radiology services. But the missing piece out of that previously had been ophthalmology. Ophthalmology at Mount Sinai at this stage does not have on-site coverage after hours, so you require for the ophthalmologist to be able to come in, dilate the eye, do fundoscopy, do OCT, or do a fluorescein angiogram, and on average that takes 2 hours or more, it seems. So that's the rate limiting step, but we worked on a solution. We'll get to that later. We'll talk a little bit about the interventional considerations, and I'm just looking at the time. We've got 10 minutes. I just need to make sure that we stay on time. But essentially, so this is the ophthalmic artery of the central artery of the retina, and you have these posterior ciliary arteries coming off separate and more proximally. And it's these arteries that can provide that cilio-retinal artery variant. Again, interesting things about the ophthalmic artery. It has an odd evolution. The adult ophthalmic artery does not actually arise from a known precursor during its embryological development. The embryological orbital supply is from a dorsal ophthalmic artery arising from the ILT. The ventral ophthalmic artery arising from a supraclinoid ICA more distal to its typical position in the adult, or the A1. And tidbit, interesting fact maybe for other kinds of non-medical kind of questions, but basically this persists in horses. And the middle meningeal artery via the meningo-ophthalmic or meningo-lacrimal branches. And this is actually an important consideration. It can persist in adulthood, and in patients that have ICA occlusion with CRAO symptoms, you can actually catheterize this branch to deliver TPA. These all involute over time, and we're left with development of the more typical position of the ophthalmic artery. Okay. So these are the collateral pathways that can get you to the eye or the orbit. Obviously, in neurointervention and CV, it's important to know about all the pathways that can communicate between the external carotid artery and the internal carotid artery, but basically facial, maxillary, and superficial temporal all have subdivisions that can anastomose with orbital branches, that can anastomose with the ophthalmic artery, and can pass on to the internal carotid artery intracranially. So these are the pathways that we can use. So the ethmoidal arteries, anterior and posterior, arising from the supramedial orbit, the infralateral trunk arising from supraorbital fissure, and middle meningeal and anterior deep temporal arteries arising from Hurdle's canal or the lateral margin of the orbital wall, respectively. And lastly, but not least, the inferior orbital and facial arcade. So we'll do a patient briefly. This is LB, 50-year-old female, sudden onset loss of vision at 4 o'clock. She was actually at the airport about to fly out of LaGuardia. Past history of coronary disease, hypertension, diabetes, and osteoarthritis. She actually has a private ophthalmologist who she managed to get to within 2 hours from LaGuardia, who examined her, dilated her eye, and diagnosed CRAO. These are the typical findings that we talk about with CRAO, so a pale disc with a cherry red macula. Or cherry red macula, sorry. Visual acuity, she had some mild, some hand movement in the left temporal field. Timeline was onset of symptoms 4 o'clock, saw the ophthalmologist by 6 o'clock, was in the MSHED by 8:39. CT brain was interpreted within about half an hour or less. And we had the patient in the interventional suite by 20 minutes past 8, and we're delivering TPA by 8:30. Essentially, we do CT heads to exclude intracranial lesions that would be exclusion for TPA delivery, and looking for other evidence of established stroke. So nothing there, no asymmetry, maybe some white matter disease on the left, maybe an old cortical infarct or developing issue in the left cerebellar hemisphere, and a CTA. Essentially, the ophthalmic artery is open. The resolution of CTA is not good enough to tell us anything about the central artery of the retina. This is the angiography. So left-sided catheter in the common carotid artery, runs of the neck, runs of the head. We don't see any real choroidal blush of the ophthalmic artery. This is overlying from bony structures. It's not the globe. These are more magnified views, so subtracted, unsubtracted, showing position of the catheter, direct cannulation of the ophthalmic artery, check angiograms proving that we're perfusing the orbital cavity. And this is after delivery of the TPA, and you can start to see the perfusion and enhancement of the choroidal blush, but also a more pronounced perfusion and enhancement of the soft tissues of the intra and extraconal orbit. And these are the final runs. So early and late, we're seeing choroidal blush, and this is the patient's details from our paper. So our light perception down to 20/50, and time to intervention of 6 hours. So we do have delays in diagnosis, and it's a massive problem. We have a system established now that's in rollout to convert CRAO diagnosis in the ED to a Teleretina service. And this has the potential to reduce the diagnostic time gap from the hours that we've seen previously down to minutes. New York Eye and Ear Foundation provided a grant to buy 3 OCT machines, which have been placed in the EDs at MSH, MSW, and Mount Sinai, Queens. This is the instruction pamphlet for the staff within the centers to use. And it really is a plug and play. Basically, you place your head into the side of the machine, fill out the details, take a picture, gives you the OCT images, and those can be relayed to the retinologist or the ophthalmologist on call. It went live at the beginning of April, and it's being progressively rolled out. The other sites, as staff are being trained. But this, to our knowledge, is a one-of-a-kind service for general emergency departments anywhere. Obviously, these systems are available in specialized ophthalmology and otolaryngology ED departments like New York Eye and Ear. And the people really championing this are these 3 gentlemen. So Michael Farrar is one of the stroke neurologists, Gareth Lima is a retinal specialist, and Richard Rosen is a professor of ophthalmology at Mount Sinai. And obviously I'm part of the team that's setting up. But what you really need is buy-in and partnership from the people that control these patients whose lives are going to be affected by on-call. So I can't say enough good things about these 2 individuals, and of course, Dr. Farrar. And this is the flow chart that we have. So patient presents to ED with acute painless unilateral vision loss, less than 12 hours, call, stroke call, retina heads up given, CT, CTA if required, history exam, retina confirmation, angio, TPA, and everything moves in series and in parallel. And what we're trying to get is a full ophthalmology consult farther earlier up the flow chart than we're seeing it currently, and removing the requirement for physicians to have to come into hospital from their home, which obviously in most cases is not within the 30 minutes that we have as neurointerventionists and stroke physicians. So thank you guys very much. Happy to take any questions, and I'm looking forward to this program, hopefully increasing the good that we can do for these patients.
Wow, very, very impressive. Art Jenkins had a question, Reade. Like, you think this could be treated like MI? And if there was some sort of suspicion in the field, give acute aspirin or something like that with a big educational program?
I'm not certain of the indication for aspirin, but theoretically, I mean, it does fit with a protocol for AMI. The only issue would be that these are neurological deficits that we're talking about, and in-field delivery of anticoagulants or antiplatelets may be a little bit of a risk, considering the differential still includes intracranial pathology until it gets better evaluated in an ED setting. So I think at this stage, it's probably not really practical until you get to the point that you have in-field triage, reliable in-field triage and diagnosis of CRAO.
Reade, I think this is pretty amazing work. And the idea of bringing diagnostic tools to the ED and getting that upfront and shortening that time. As you know, the biggest bane of our existence is delayed presentation. I guess one thought is, I'd love to get your thought and share with the group. And I think Dr. Rudolph just put a question about this. While time is absolutely crucial for getting the patient treated quickly, getting a good outcome from the patient, do you see there being a downside for a patient who's presenting at a delayed time period or is a wake up discovery? My impression is there's relatively little downside to giving a couple milligrams of TPA into the ophthalmic artery, and it might be something worth doing, even if it's just to make sure everyone's thinking about it and pushing it and trying at all times, sort of grease the process to make sure it's occurring efficiently. I'd love to get your thoughts.
Yeah, I mean, I talk about the 15 patients that we published on, and that's obviously not the entire complement of patients that we've intervened upon. We chose that as a line in the sand, basically on the background of the Eagle study and the data that they showed for intervention at or around about 10 hours on average, even though they showed that there was a significant trend towards improvement with early intervention. I think that we've shown, at least with our technique and with the Hopkins protocol, that the intervention is safe. Safe in terms of the risk of causing complications related to bleeding. Really, the question that's unanswered is whether intervention after 24 hours is going to provide any kind of improvement in the long run. The data that we have suggests that any improvement that you really get in perfusion or recovery happens up to 1 week after ictus, after presentation with CRAO. I think we've got pretty good data, at least showing, following these patients now out to at least 3 months, that shows that they don't really have a progressive improvement after the 3 weeks that we see them. And I guess that's a long, kind of complicated way to say, I don't really know. I don't think that we do harm, but I'm not sure about what some benefit is going to be, and we just don't have the numbers really to say more than that in a really informed, evidence-based way.
Fantastic presentation, Reade. A quick question: with the new data building showing that there's more higher recanalization rate with TNK, can we see a role for TNK for CRAO?
I don't know the answer to that. Interestingly, the paper that was published on IV TPA, the randomized trial, which came actually out of Melbourne, RMH, was co-authored by Bruce Campbell as well. And obviously they have run prospective ELVO trials looking at TNK. I'm not sure whether that's something that's on the radar for them as well, but it's something that certainly might show benefit.
Yeah, because we know that if you recanalize the artery, the outcome is going to be better. And now you know that the recanalization rate with IA thrombolytic agents are higher with TNK. However, it's a difficult patient population to study because of the rarity of the pathology.
It's rare, and I think some of the issues with IA-TPA has been finding what the appropriate dose was to avoid the complication of bleeds. When you start throwing in a new medication to the mix, then I kind of feel like it might be setting back the clock a little bit, where you really have to almost do like a phase 1 trial specifically to find out what the safe dose is for delivery.
Yeah.
So
that's correct. Thank you.
Have the dose for IV, so that's been determined mostly by the Australians. That's what Sharam mentioned, the study about looking at people prior to mechanical thrombectomy. But I wanted to make a comment about increasing the number of treatable patients. As long as we have OCT available, the Germans just published last year that they could time the onset of the CRAO with OCT. So it's the equivalent of what we do with wake-up stroke, where we're looking at the difference between the flare and the diffusion. So it may be possible to increase the number of patients.
How do they do it, Steve?
Well, they had patients where they had the known time of onset, and they have OCTs at different time points. It's an act ophthalmologic. I'll send it to Reade so he can send it around.
I think that'd be great to look at.
The other issue is the American Stroke Association just issued a scientific statement on CRAO.
Yeah.
It's in Stroke last month, and it encourages IV at less than 4.5 hours and endovascular therapy beyond that point. So the real issue is getting the ophthalmologists to know this. We did some outreach here in Brooklyn. We just contacted almost 100 ophthalmologists, and we haven't done a formal survey, but they were not aware of any of this data. So my question is, if you have a good ophthalmologist, does an OCT in their office, do you need to go any further, or can that patient be directly referred for endovascular therapy?
My understanding from OCT is that the diagnosis is fairly evident, and it's there to exclude other kinds of intraocular pathologies like retinal detachment. So if it's consistent and convincing of CRAO, along with a history that fits, then I think that there's certainly room for incorporating that into a direct to angio or an expedited treatment protocol.
And just in terms of what Jay said, don't you think that at some point the OCT can exclude patients from therapy, that you can see when it's just too far gone?
Theoretically, I mean, I would have loved to have Dr. Lima or Prof. Rosen on the call to answer that, because that's out of my clinical bandwidth, to be honest.
Because once you see the cherry red spot, I mean, they're still treatable, but we know now from looking at this over a period of hours, and that you can identify it on OCT before you see anything in the retina, that there are some people that we can get very early if the ophthalmologists are brought into this. So I've been speaking to Lima about this,
Yeah.
you know, putting together a CME, a lecture for them, kind of an update on stroke that focuses on CRAO.
Mm.
And we'll be doing that, so we'll drag you in.
Perfect. I mean, we've been talking, Gareth and I have been talking about, you know, Mount Sinai is a system that is so well greased and well oiled and structured for stroke intervention. All the pieces are there for the final part of the puzzle. Really, where there's an issue and a limitation is the early education and the referrer education.